Good morning, everyone. Welcome to the Medicaid Monthly Virtual Meeting. We'll just give it a moment as folks come in from the wait room. All right, good morning. My name is Veronica Judy Cecil. I'm Senior Deputy Commissioner for the Department for Medicaid Services, and welcome to the Medicaid Monthly Virtual Meeting. We appreciate you all joining us today live, or for anyone who may come back and watch the recorded version, which will be posted along with the PowerPoint presentation following the meeting. Generally, it takes just a couple of days to get that prepared and posted. Next slide, please. Our agenda, as usual, is very packed and with really hopefully great information to share with folks who are joining. We'll do our regular Medicaid renewal and our state-based marketplace update. We've got updates on the 1915I RISE initiative, our reentry project, our 1915C Community Health for Improved Lives and Development waiver. We have a sister agency spotlight this month. The Department for Community-Based Services is going to talk about the federal legislation, House Resolution 1, that was passed and signed into law on July 4th, and its impacts to SNAP. So we appreciate our sister agency being with us today. We've got our monthly, our Healthy Kentucky Home Spotlight given by Medicaid Medical Director, Dr. Judy Terrio, and this month is about obesity. And then we will provide an update on HR 1 and as it relates to Medicaid and some other provisions. So let's get started. Next slide, please. This is our typical snapshot just to kind of show the overall enrollment trend as a result of renewals. And as you can see, we're still staying a little bit steady around that 1,450,000 individuals enrolled. We had a little bit of a dip, and that was related to the child renewals that restarted with July renewals. So we did see some children unfortunately drop off, but some of those are due to no longer being eligible. And we're working very hard to make sure they have other coverage or connected to other coverage. Next slide, please. So speaking about Medicaid renewals for the last month that we completed renewals, which was August, as you can see, we had 46,202 individuals who went through a renewal. We had 41,559 approvals, and the majority of those were what we call our passive or automatic or ex parte renewals. That means that we were able to go out and check data sources, various data sources, and determine somebody's eligibility without them having to take any additional action, without the need for any additional information. So that's what's called a passive or ex parte approval. The majority of those, around 80% is what we're averaging per month in the renewals that we can go out and do that automatic renewal for. We did have 4,392 terminations, and at the end of August, on August 31st, as we transitioned out of the month, we had 251 cases pending. What that means is that someone has returned information, but the state hasn't been able to process that case, and they're considered pending when they cross over. Next slide, please. These are our renewals by age, and on the left side, the colorful lines indicate who's approved, and on the right side is who's terminated by age. So the darker blue on the far left is 0 to 6 age. The orange next to it is the 7 to 18 age. The next gray slide is the 19 to 25 age. The largest number there is that age group of 26 to 50, and that's in yellow. The lighter blue to the right of it is age 51 to 64. And then the green is for those folks who are age 65 and older. So as you can see, we've started providing this information just so folks can see primarily an interest in the children renewals and where that is or where it falls in terms of approvals and denials. Next slide, please. So speaking of children, what we're showing here is in the blue are child renewals for August that were approved, and in orange are those who were terminated. I talked about passive, that way that we automatically can approve somebody based on the data that's available, the different data sources that are available to us. And as you can see, the majority of those, very large number, were able to be automatically renewed without what an RFI is, which is a request for information. So we do go out and try to verify the information. If there's just something we can't verify that way, we will drop it to and send a request for information and a notice to the member to try to provide that verification for us. That's the middle column there where it says passive with RFI, meaning we had to send something just to request some additional verification. And if those folks received that and responded, then you can see that they were either approved or terminated. The far left bucket are folks that we are not able to just automatically go out and do and perform that passive. We attempt it, but then they have to drop to an actual active renewal. And so they receive a full renewal notice that we ask them to verify the information and then send it back with any documentation that's needed. So as you can see under the, for those who fell under an active renewal, the different numbers between how many were approved or terminated. Next slide, please. And then for those children who were terminated, this is showing you the reason. And as typical for Medicaid, when folks are being terminated during their renewal, the largest amount is always that failure to return the form. We had 704 cases or child cases where the information was not returned to us. There could be varied reasons for that, including that the member might have, the parent or guardian might have thought that the child was no longer eligible because they were not eligible. We are always, and we'll talk about this a little later, trying to emphasize to families and guardians and those who are supporting children with a renewal to go ahead and send it in and let us make that determination, because the income levels for eligibility for children are higher than those for an adult. So sometimes adults don't understand that that child could still be eligible for Medicaid. So we do encourage folks to always just return the verification and the information and let us make that determination. That middle graph there is those who were actually determined ineligible. So the information was provided to us after we requested it, and they were determined ineligible. And then that bottom bucket, that renewal then prompted somebody to request that they be disenrolled. That happens frequently as well. So that's what that other bucket is. Next slide, please. So just a reminder for folks, currently we do renewals every 12 months. Not every single Medicaid member is subject to a renewal. There are some folks enrolled in Medicaid because of their category. For example, Foster children are enrolled in Medicaid. They do not have a regular renewal. Their category of being a foster child makes them eligible, and when they're no longer a foster child, they could move into a former foster coverage, but so it's that eligibility that category that makes them eligible. So they don't have to go through a renewal, but we do still have a lot of individuals who have to go through renewals. The most important thing is to keep information updated. So we do encourage our members to make sure that when their address changes, if they've got a new phone number, an email address, if any of that information changes, that they provide that to us so that we can make sure that we are able to contact them when it is time for them to renew their Medicaid. We do send a renewal notice at least 45 days before the due date. And the due date is always the very last day of the month, is the renewal due date for our members, the month of their renewal. So we start that process actually at the beginning of the month before. So for example, for those who have a September renewal, we started their renewal at the very beginning of August, and we have attempted to do that passive renewal for folks. So if we could automatically renew them, but if we can't, then we drop down and provide either that active renewal notice or that request for information if we weren't able to successfully passively renew them. So all that happens way before their actual renewal due date. And then as their renewal due date comes up, so as the end of September approaches, about 15 days before the end of the month, we will send a reminder to folks who haven't responded. If we've not received anything in response to a notice or request for information, they will get a reminder. Everyone's renewal month is available. If they're trying to find out when that is, they can log into their self-service Connect portal, or they can call Connect. They can call the 855-459-6328 number and provide information to confirm their identity, and then we can certainly provide that renewal month. Providers, Medicaid providers, also have access to the renewal date in Kentucky Health Net. So a provider that is seeing a member as they come in for maybe an annual visit or they have some other visit, they can check to see when that renewal month is and support the member by letting them know, especially if their renewal is that month or a month that's coming up. And then, of course, we always just want to encourage folks to send the information in as soon as possible, or to reach out to us if they have questions about it. We're happy to help people figure out what they need to provide and how to provide it. And so if they would call when they receive a notice, we can help them that way too. And then we have lots of folks across the state to help. We have connectors and insurance agents who can help both apply and renew Medicaid. So there are folks across the state to help individuals that might need that direct support. But if coverage is terminated and somebody reaches out within 90 days to submit the information, we can reactivate the case. If it's outside the 90 days, you might hear them call it a reapplication. And so that just means that there might be additional verifications that have to happen if it's outside that 90-day period. Next slide, please. These are just talk through some of our outreach strategies. As I mentioned, if we've got a phone number or an email address, in addition to a written notice, we always try to text, email, or call individuals to make them aware that they have to take action. So if they're one of those members whose renewal we couldn't automatically verify and automatically renew them, then we try to reach them to tell them they have to take action or they might be terminated. So we do that through all the communication modes that are available to us. Through our managed care organizations, we provide them lists of who is going through a renewal of their enrollees in their MCO. And those managed care organizations also reach out to members that are still going through that active process of having to provide information. And so they may also be texting or calling or sending letters. In fact, recently we had a member reach out because their MCO sent them a letter and said, "Hey, you got renewed. There's nothing more you can do." And the member just wasn't sure if it wanted to confirm that that was accurate, and it was. Like I said, the managed care organizations are really trying to help us support members as they navigate the renewal process. And then I mentioned the connectors. Our wonderful connectors across the state are available, and they are available in all 120 counties, as are our Department of Community-Based Services offices, local offices. And then for children in particular, we have partnered with the Family Resource and Youth Services Centers, the Friskies, which are in almost every school, and are working with them to make sure they know and understand about renewals and child renewals. We've provided them information to help support and know what to do when they come across somebody who needs that help. And connectors can be found either by calling the Connect hotline, that phone number 855-459-6328, or going to the Connect website, connect.ky.gov. There is a way to search for or locate a connector or insurance agent that can help people. Next slide, please. We still have a lot of communication materials around renewals that remain on our website. We did transition a few months ago from the Public Health Emergency Unwinding website to our new Medicaid renewals site, but all those wonderful and helpful communication materials are out there and still available, and we just encourage folks to utilize those, to pull it down, providers to post it in their offices to help our members navigate renewals, community-based organizations or advocates to utilize them to help communicate with members and remind them that the renewals are still happening. So we just encourage folks to take those down and utilize them. And if there's something that is missing, if a new communication material is needed, we always encourage folks to reach out to us and let us know. We're happy to provide and work on the creation of new materials if it's helpful. Next slide, please. And we did do just that for child renewals. The Restart of Child Renewals gave us an opportunity to do some communications specifically around that. And this is, you see on the slide, some examples. This is on the Medicaid renewal website. There's a toolkit with frequently asked questions, but hopefully enough information for all those who are out there wanting to support child renewals and our members navigating child renewals is out there and available. And we just encourage you to utilize it. Next slide, please. And we always are encouraging our members to utilize the toolkit that we created and is available on our member website. And that helps folks understand the program, what their benefits are, what to do if they need help, and what to expect and how to access services. Next slide, please. And this is just an example of our website. The renewal information that I went over for August, there is a report that we submit to the Centers for Medicare and Medicaid Services. That report is all reports to CMS on renewals is on that website. So if you really want to get more information, a little bit more detailed level on those renewals, those reports are there for your use. We also update those reports after 90 days to report any pending cases. So as I mentioned at the end of August, we had some pending cases. in 90 days, we'll send an updated report to CMS about how those cases were processed and who was approved and who was terminated. So those reports are also on the website. Next slide, please. And now I'm going to shift to our state-based marketplace. So the Connect also has the state-based marketplace. So it's not just for Medicaid or for all other benefit programs under the Cabinet for Health and Family Services like SNAP and TANF. Our qualified health plans are also on the Connect. And we just wanted to note a few things for folks. And one is HR1 again, as we continue to talk about that. It did make a change in eligibility for the marketplace plans. And it had to do with immigrants and their immigration status. And so we are providing outreach to those folks. We've been doing that over the last month, but just continuing to make folks aware that there was a change in certain eligibility requirements for the marketplace plans. We also want to make sure folks understand the enhanced tax credits that have been available and have made these plans and premiums more affordable are going away. And unless Congress acts to extend those enhanced tax credits, after this year, the premiums for next year, unfortunately, are probably going to be higher. And so we are just trying to make folks aware of the fact that your premiums are probably going to go up. It depends on the plan. And we're going to be providing that detailed information as we release the plans and their rates in October. We're going to try to keep folks updated on what that means to them at an individual level. And we're going to encourage and continue to encourage Congress to extend those tax credits. So for plan year 2026, just open enrollment is November 1st, 2025 through January 15th, 2026. The bronze, expanded bronze, catastrophic plans to Connect will also be compatible with private health savings accounts. So again, more information on this as we approach October and the open enrollment, and we'll keep folks updated on what's happening with the enhanced tax credits. Next slide, please. All right, I'm going to turn it over for an update on the 1915 RISE initiative.
Good morning. Glad to see everybody, and glad to be back to give you another update on the 1915 RISE initiative. My name's Tanya Dickinson, and I'm with the Department for Behavioral Health and helping implement that program. The 1915 RISE initiative is a joint effort of Department for Medicaid Services and Department for Behavioral Health, Developmental and Intellectual Disabilities, and focuses on helping individuals rise above their challenges through services that promote recovery, independence, support, and engagement in the community. I've got a quick overview of the program and where we are now with it, and then we'll get to it. The 1915 RISE initiative is a new Medicaid benefit under the state plan. And although it's similar to the 1915C waivers like Michelle P. or SCL that you're familiar with, it is distinct as an amendment to the state plan and does not have a limited number of participant slots. Although we anticipate serving about 5,000 folks the first year. The participant services will be billed directly to Medicaid and not through MCOs. We began accepting provider applications for certification to provide services on July 1st, and we'll announce the date to start enrolling individuals into the program soon. Please visit our webpage, if you would, at dbdid.ky.gov and navigate to the 1915 RISE initiative to learn much more about our program and services. Oh, no, I'm still back on the slide before. There we go. Um, it's designed, the program is designed for Medicaid eligible adults who are 18 and over with serious mental illness, with or without a co-occurring substance use disorder. We've had some hospitals inquire about making referrals, plus families, guardianship, etc. And until we're able to accept participant referrals, you can send an email of interest to 1915I RISE initiative at ky.gov, and we will add you to our follow-up contact list. The 1915I RISE initiative brings 10 essential home and community-based services into the communities. Each of them have specific requirements and limitations for participation, assistive technology, things like medication reminders, case management. All participants in the program do have a case manager who helps them access all of the other services that they receive. We have housing and tenancy supports, in-home independent living supports, medication management, planned respite for caregivers, supervised residential care, supported education, supported employment, and non-medical transportation. Participants receiving any of the housing services must be homeless or at risk of homelessness, formerly homeless within the past 24 months, or now residing in a HUD-assisted housing program, and have a history of frequent nursing home or inpatient stays. They may be preparing, in fact, to exit a institutional setting as they enter this program. Services can be received along with other complementary programs that participants are already working with, like assisted outpatient treatment or sort of community treatment, as long as they are not duplicative. Providers are go through a review process, an orientation process with an online class and some online materials, complete a certification application and submit it to us. And providers can email us any questions that they have at 1915I RISE provider at ky.gov. And I'll put the emails in the chat when we're done here. And we'll be happy to help them. We will review their packets when they certification application packets when they're submitted, and answer any other questions. We also have for providers technical assistance that we provide to them as we go along. And if you would like to be a provider, we would love to get to know you better. Next slide, please. Some quick updates about where we are to date. We have over 100 service providers who have registered to begin the certification application process. Our core staff are now in place, providing technical assistance and certification reviews to the providers. We have, in order to help provide some technical assistance and get some more information out there, 2 office hours that we sponsor each week. That are basically webinars that are open for anybody who's got an interest as a provider in joining the program. They're 3 to 4 p.m. Eastern Time on Mondays and Wednesdays on Zoom, and you can find the link for that on our website. I'll also put that in the chat, our website, so that you can access all that information. And then we have the 2 different email addresses there that are available to communicate with us. All I can say is it's been a great adventure, and we are having a lot of fun getting this up and implemented and ready to go. And our providers that are in the certification process, they're all eager to become certified so that they can start providing these services. And that's all I have for folks today.
Good morning. Sorry, I was having a hard time getting my microphone to unmute itself. I'm Kristen Schroyer. I am one of the behavioral health specialists within the Department of Medicaid, to bring you an update about our reentry. Next slide, please. So just a reminder to to those of you who may have not heard for a while about the program, our reentry is for all adults and youth who would be eligible for Medicaid if not for their incarceration status um, within the state prisons and the youth development centers, with the goals of providing case management 60 days prior to release and then up to 12 months post-release, medication assisted treatment starting 60 days prior to release, and then a 30-day of supply of all clinically required prescription medications, and when applicable, durable medical equipment as well. So our program design for the delivery of the pre-release services is ongoing. This is a very, very big project for us. There are multiple systems involved, multiple partners involved, and we continue to get together with collaborations, trying to work to get our system alignment across all the platforms with all the systems. Like I said, there are many systems involved. And we are hoping to continue our testing of those systems through the end of 2025. We're deploying as far as 10-1 goes, and then the goal of a full implementation by 2026. So we're going to continue to work with our justice partners. We're going to get through the credentialing process, work with our managed care organizations, and then we are also working on our provider training and readiness. Training will include like billing, medication PAs, case management delivery. How are those systems going to work in the pre-release field? And so again, we'll continue that through the end of 2025 and into early 2026. Next slide, please. For the CAA, which is our Consolidated Appropriations Act, this is for our youth who are Medicaid eligible at incarceration or are found eligible during their placement. So under age 21 or former foster care youth 18 to 26. Right now, or as we do this for now, it will be within our state prisons and youth development centers, much like reentry. So the services for those in CAA is going to be the screening and diagnostic services. That includes medical, dental, vision, behavioral health screenings, and diagnostic services 30 days prior to release. And then targeted case management 30 days prior to release and for at least 30 days after that release. We have a state plan amendment that's been approved. And our CAA grant, which we applied for, has been awarded, and we just had that state kickoff call with them last month in August. Full implementation for our CAA across all state prisons and the YDCs is going to, we're working to align that with our reentry project as we go along. So these are very intertwined. That's why we often report on these together. As you can see, they're similar in some ways and different in others. And we are just going to continue working through to get this implemented. Hopefully, all within the beginning of early 26 with deployment starting this fall. And that's all I've got.
Good morning, everyone. Excuse me, Carmen Hancock, Division Director for Long-Term Services and Supports with Medicaid. I'm here this morning to talk to you about the 1915C Child Waiver, Community Health for Improved Lives and Development. Next slide. For those of you all who have been on these forums and have been to meetings and other events, you have seen this slide before. Just to refresh your memory, the child waiver is a part of the Families First initiative. This is a comprehensive multi-year initiative aimed at enhancing the existing system of care for Kentucky children and youth. There are several stages, and this is again multi-year. This has been in the works for quite some time. At this point, we have already achieved many of these goals. Shine Kentucky, Kentucky Cares, that's supporting community reentry, the CHI mapping tool. This is a tool that has been created so that we can better track and report all of the child wellness initiatives throughout the cabinet. Restructuring of Medicaid payment for medical necessity, so funding modernization. So in this spectrum, this Families First initiative, we are right now at the bubble there with the hands and the heart, the high needs service delivery. And that is the intent of the 1915C child waiver, to meet those child-centric care and support needs. And then we have one more step, and that is in the works in the future, the Child State Plan Amendment. So we are planning for a SPA to just round out that Families First initiative and that comprehensive system of care for children. Next slide, please. So what is the 1915C child waiver? Again, community health for improved lives and development. This is a new 1915C waiver, and it's designed to help Kentucky children and youth with significant behavioral health or developmental challenges to get the services they need while being able to stay at home, go to their school, remain in their communities, and stay active and engaged. This is intended again to serve the children with the most complex needs. So, focused for children or youth who might be stepping out of an acute psychiatric inpatient admission, potentially at risk for out-of-home placement due to intensive behavioral health or residential support needs. The child waiver does include clinical and therapeutic services, which are designed to have like a step-down approach or a transitional period for children coming from the highest level of care so that they can successfully return to their homes and their communities. Right now, the anticipated go-live date is the beginning of January 2026. Next slide. So again, this waiver is intended for children and youth up to the age of 21, the most significant behavioral health or developmental needs. The level of care would be for someone who needs something similar to a psychiatric inpatient facility or hospital, or an ICF-ID, intermediate care facility for individuals with developmental disabilities. Children who take part in this waiver do need to be able to be safely supported at home or in their community, again, with the right package of services and supports to help them. Next slide. So here's where we are. We have all of Medicaid and our sister agencies, Department for Behavioral Health and Intellectual and Developmental Disabilities, Department for Community-Based Services. We have been working diligently over the last few months to ensure that we can have a successful go live in January. So we did go out, we put the waiver out for public comment. That public comment period ended on July 15th. The responses to those comments were compiled and posted out to our website on August 21st. We did make revisions to the application, to the waiver application, based on that public comment. It was reviewed, obviously, by our executive leadership, all the way up to Secretary Stack. We made the revisions to the waiver and resubmitted that to Centers for Medicare and Medicaid Services on August 20th. Like I said, responses to public comment were posted on August 21st. We worked on developing regulations. We needed to develop regulations from the ground up because this is a new program. So both the services waiver, the program requirements, and the reimbursement waiver are in the process of being reviewed and approved through all the necessary channels there. The new waiver numbers are 907 KAR 2.720 and 2.725. So we are continuously developing systems, working on the procedures for operations and implementation. We're working on communications, training guides, provider orientation, standard operating procedures, and so forth. So we are diligently, like I said, working to get this program where it needs to be by the beginning of the year. And I think that's the last slide here. Thank you.
Hello, everyone. My name is Amy Smith, and I am an executive advisor with the Department for Community-Based Services. And I'm going to talk about HR1 and the impacts to SNAP. Next slide, please. We serve roughly about 597,000 individuals on SNAP, and so many of those individuals are also on Medicaid. And so I think it's relevant to talk about those changes to SNAP as well. So many of you obviously know HR1, but obviously wanted to put that out there and what that refresher. Obviously, that was signed on July the 4th of 2025. Many of HR1 aspects are going to go into effect on October 1st. So initially, the changes to the Thrifty Food Plan is going to limit the way that the Thrifty Food Plan is going to be updated in the future, which means that SNAP benefits may not change or keep up with the pace of inflation. So as inflation goes up, the calculations for SNAP will not change, meaning that individuals will not see their SNAP increase with inflation. So it also is going to make it more difficult for families to stretch their food dollars, their food budget. Uh, a lot of the information, though, that we're still waiting on a lot of implementation guidance from the USDA. So I'm sure, just like our Medicaid partners, we're still waiting on some of that guidance. Next slide, please. There are changes to our SNAP work requirements for able-bodied adults without dependents. So right now, an adult is defined as an 18-year-old to age 65. This was 18 to 54. And so this was something that was immediately changed upon signage of HR1. A dependent is now a child less than 14, which was 18. So for instance, an able-bodied adult without a dependent. So for instance, that individual, when it was 18, if they had a 17-year-old, they still had a dependent. Now it would have to be a 13 and under. So that's going to open up the individuals that are now qualifying as an able-bodied adult without a dependent. Some of our ABOs are also no longer exempt from work requirements. Previously, homeless or unhoused individuals, veterans, and our youth, which are transitioning from 18 to 24, that are transitioning out of care, were exempt. Well, they will no longer be exempt from that work requirement, and they will now have to meet those work requirements. Next slide, please. We are also going to have changes to our SNAP ABOD waiver. So currently, Kentucky waives 117 out of 120 counties for the ABOD work requirement. So under HR1, only counties with an unemployment rate of higher than 10% will qualify for the waiver. Previously, states that had an unemployment rate of 10% and also had no job availability. There were just no jobs in that area. So combined with that unemployment rate, they would qualify for the waiver. That is no longer the case. So under the new rules, Kentucky will no longer meet the waiver requirement. So when the waiver expires on December 1st, ABODs in all 120 counties will meet the work requirements. And then we will also have those individuals who no longer meet the exemption qualification, which they will now have to meet 20 hours, which is 80 hours monthly. So we anticipate having up to 63,000 individuals that will suddenly become ABOD eligible and have to meet a work requirement in Kentucky. Next slide, please. There are also additional changes to what we call our standard utility allowance. A standard utility allowance, or the amount, it represents a household's total utility costs. And it's in lieu of their actual costs because, as we know, families' household costs are going to vary. So this is a general cost that's determined, that helps determine eligibility and benefit amount in SNAP. Households that receive energy assistance, such as LIHEAP, automatically receive that standard utility allowance. But there is going to be a difference with HR 1, which limits that SUA to households with an elderly or disabled member in their household, which again reduces that eligibility population. So we are going to see that that SUA may either reduce, or it is going to reduce not just the total of SNAP benefits, but the individuals who are eligible to use that SUA benefit. In addition to that, there are also internet expenses, which if we've been able to include in that SNAP calculations, households are no longer able to claim that internet expense as a part of their excess shelter expense deduction. Um, so this may affect a household SNAP eligibility in total. So again, individuals may see a reduction in their total SNAP benefits due to these two changes. Next slide, please. There are also additional shifts in the cost to states, which you guys may have heard about, administrative costs. So reducing the federal contribution towards SNAP administration. There is an increase to the state's share, the state's responsibility of SNAP administration costs. Previously, that's been a 50-50 split. Is now going to be a 75-25 split. Matching requirements, HR 1 requires states to provide matching funds based on our payment error rate, which is on the next slide. And next, there you go. So the payment error rate occurs when a household receives more or less than their correct amount, and it's set at a $57 tolerance level. So if there's an error on the case, either an overage or under amount, and it's going to be over $57, that contributes to a payment error. So the USDA calculates that payment error rate for every federal fiscal year. And every June, USDA analyzes that information. And then the SNAP payment error rates are identified through our quality control process. Some states are seeing as high as a 13% payment error rate. We're really excited that right now our payment error rate for the last notification from FNS is at 3.1%. And we are the second highest, or second lowest rather, I guess, in the nation. So right now, Kentucky is in a really good position that we need to hold. Next slide, please. And you'll see why that's important here. Because the matching fund requirements, states with SNAP payment error rates above 6% must match federal funds provided for benefits. So for states with a payment error rate below 6%, we do not have to have a state match. But anything above 6% is when we have to start contributing to that state match. Now that does take effect October 1st, 2027, but anything from 6 to 7.9%, we would have to have a 5% state match. From 8 to 9.99% is a 10% state match. And then 10% or higher to 15% state match. And of course, anything higher, I haven't seen anything higher than 15%, but with states, but of course, that's a 15% state match as well. So again, we want to really keep that payment error rate low so that we can keep that match down to 0. Next slide, please. And then finally, alien SNAP eligibility. A lot of this, we are still seeking guidance on implementation, but there are changes to the SNAP eligibility related to our citizenship status, first resident of the United States, and then either one of the 4 categories below, a citizen or national of the United States, which national was added to that definition. There is the alien lawfully admitted for permanent residence as an immigrant. So it's the same definition, but there's an exclusion. And then an alien who has been granted the status of Cuban and Haitian entrant, or an individual who lawfully resides in the United States in accordance with a compact of free association. So there's some slight changes to that SNAP eligibility, which will reduce the amount of individuals who will qualify for SNAP. Next slide, please. So if you have any questions, please feel free to email me. We are still again seeking guidance from our federal nutrition services, and still guidance is slowly coming out to us, but happy to answer any questions regarding HR1 and the changes and implementation in the future. Thank you.
Hello, everybody. I was going to talk a little bit about our Healthy Kentucky Home, and this month we're going to spotlight obesity. Next slide. Just to kind of set the stage, in Kentucky, about 32%, a little bit more than 32% of adults report being overweight, and more than 38% report being obese. And that's just in our state. So that's pretty much 3 out of every 4 people have a weight that is higher than it should be for being healthy. So next slide. So when we talk about obesity, it's really complex. It's lots of factors that go into it, and it's kind of like it's the end result. So it's like a fee appropriately, you have to kind of figure out what to treat first. And obesity is the same thing. Lots of things cause it, lots of things contribute to it. The end result is being obese, but you have to figure out what's causing it to figure out what you need to do to treat it. One good thing, and something that we've been talking about all year, is incorporating the simple, achievable lifestyle changes in your daily routine can give you the power to reduce your weight. And the reason for that, the reason that we are interested in that is because once you get that you get up in weight and you're obese, that can lead to all kinds of other things. It can lead to diabetes, it can lead to joint problems, sleep apnea. We want to decrease the chance of our citizens developing some of these other conditions that can really affect your life. When doctors talk about obesity, they usually say the words BMI, or body mass index, which is another number that they calculate. And next slide. And that gives people an idea of where they are compared to others. So this is your wonderful body mass index table, and it's highlighting it. Well, on the left side is your height, and then across the bottom is the BMI, and then all of those boxes in the middle are weights. So what's highlighted is a person that is 5 feet 5 inches, and they are 144 pounds. And so if you go down, that means their BMI is 24, which is in that healthy weight range for BMIs. Unfortunately, I am not 5'5", I'm 5 feet. So if we go up and look at the 5 feet row and go over to 144, so I would weigh the same thing as that person that's 5'5", I would be in the upper part of the overweight range on that chart. So you can see it's got it depends on your height, it depends on your weight. The problem is they don't calculate in other things, like if you're male or female, how old you are, different things like that. So you kind of have to take that number with a grain of salt, just like your weight. So you don't want to get fixated on these numbers, because honestly, you don't want to care about those numbers. You want to care about being healthy. So next slide. This is just case in point. This is Arnold Schwarzenegger with, and he won Mr. He's 6'2". I think he was 240 or 245 pounds at this point. And so if you put him on that BMI table, he would be obese. He would have a BMI of 31 and he would be obese. Clearly, he has absolutely no fat on his body, so he is not obese. He's the opposite of obese. But again, just to show you that is just a number. So next slide. So the reason we gain weight is because our calorie intake is not balanced with the calories we burn. So if you imagine the scale, this balance, and okay, what's going in your body, if it equals what's going out, you're balanced. So the calories you're eating, the protein, the fat, the carbs will be balanced with whatever you're burning. And exercise, we know that if we exercise, we're going to increase the calories out, and we may or may not lose weight. Daily activity is another big thing that goes into it. And I can tell you my daily activity is sitting in front of a computer for most of the day. So whatever calories I'm burning on that activity is not that much. Now, if I waited tables, I used to wait tables. If I waited tables and I'm running around all day, serving people, well, then my daily activity is a lot higher. So I might, on a daily basis, burn more calories than I do now. But the kicker is that resting metabolism. That's the base of the calories going out, the energy going out. And that is different for everybody. And that, a lot of the time you don't have control over it. So that's, how old you are. If you're male or female, men have more muscle mass, they burn more calories just by sleeping. 14-year-old boys burn more calories by sleeping than 61-year-old women. So it depends on your gender, your age, hormone levels in your body. Excuse me, such as menopause. When women hit menopause, their metabolism goes way down and they burn a lot less calories just by doing nothing. And genetics plays a big part in it. So, what helps somebody lose weight is going to be different than what helps somebody else. But you can, put it down to this very basic, what's going in your body, what's going out of your body. So next slide. So we're our healthy Kentucky home, right? So what's one of the things we've been talking about this whole time is increasing fruits and vegetables. So if you can increase your intake of fruits and vegetables by 2 servings a day, you're going to be on the road to having a healthier diet, and that's what we're looking for. Next slide. So eating healthy or healthy eating patterns really help you live longer. We're about to go into cold and flu season, so it will strengthen your immune system, getting all those vitamins in, and you're going to have less chronic diseases. So next slide. Physical activity. If you're exercising, you're burning more calories. You're gonna adjust that scale in the direction that you want. So regular physical activity is really going to help you maintain a healthy weight. You don't want to get bored. You want to try different things. You want to find something that you actually like because you don't want it to be a chore. And we're advising to start 30 minutes a day, 3 days a week. And probably the most important thing is to getting an exercise buddy. So next slide. Surrounding yourself with supportive friends and family. So engaging with others. That's our third important pillar in our Healthy Kentucky home. And this will really help you to, when you're engaging with others, when you have an exercise buddy, when you have that accountability with somebody else, that's going to really help you to continue your lifestyle changes. So next slide. And we just said that. So next slide. So in summary, the 2 fruits and vegetables a day, exercising 30 minutes 3 times a week, and connecting and engaging with others. These are going to increase your overall health. You'll have a higher energy level. You're going to sleep better. You're going to reduce your risk of developing chronic diseases, and it may help you lose weight. But remember, don't get stuck on those numbers. Just get stuck on getting healthy. So next slide. And this is just some websites that you can go to if you want to learn more. And that's it. Thank you.
Thank you, Dr. Terrio, and I appreciate folks hanging on. I know we're running over. So we'll do a quick, if you're able to still stay on, or please check out the recording after we post it if you want to, don't have time to hang on. We're doing a quick update on House Resolution 1. Last month, I did present on various different provisions within HR 1 and its impact to the Medicaid program, including particularly for the expansion population, that they'll have to start community engagement requirements, complying with community engagement requirements. We'll be performing a 6-month redetermination on those folks. And those are provisions that take effect January 1st, 2027. So we still have some time for that. And then cost sharing, but that does not take effect until 2028, January of 2028. But so what we want to just talk with you today, next slide, please, is about the Rural Health Transformation Program. This has a more deadline coming up before some of those other provisions. And just to remind folks that this is a grant funding opportunity from the U.S. Department for Health and Human Services through the Centers for Medicare and Medicaid Services. $15 billion dispersed across the fiscal years 2026, federal fiscal years 2026 to 2020. The HR 1 indicated the grant funds have to be distributed by December 31st, 2025. 50% of it is going to be distributed among states with an approved application. And then the other 50% is going to be awarded to states based on a lot of other metrics and other factors. Next slide, please. The program has 5 strategic goals, and I'm not going to go through every single one of these, but as you can see, they're really focused on how to transform care in the rural areas and focus on things like workforce and technology. Next slide, please. The update we really want to provide to you today is that CMS did release the Notice of Funding Opportunity. That's we also call a NOFO. That was released on September 15th. It now gives us a lot more detail into what the application is going to look like and what CMS is going to require states to provide as part of their application for approval. The deadline for states is November 5th. That's not very far away. And so, we're going to be quickly working to try to meet that deadline, because the states only get one application, so one application per state. And this is the only opportunity to apply for these funds. If a state misses that deadline, they do not get access to any of the funds that are part of the program. Next slide, please. You all may recall, and we discussed, that the state issued a solicitation to a long list of organizations across the state. The list included organizations that are provider organizations, that are rural health organizations, that are advocacy organizations. And so we asked them to provide some input. Of course, this was before we had any information about the application itself, but to provide input into ways that Kentucky may be able to utilize the funds to transform rural health. And so we did receive over 50 submissions. We still have submissions that are coming in. And we encourage folks that have ideas about where we can transform care in these areas to submit those to us. We do plan additional stakeholder engagement as we work to develop the plan, and those will be announced and be shared through our email distribution list. So if you're not signed up with the Cabinet for Health and Family Services email distribution list and for Medicaid, then please do so, because we will share updates and information about the Rural Health Transformation Plan through that communication. Next slide, please. So that is a very fast update on HR 1 and what's happening right now. And we always encourage folks to let us know, what do you want to hear about as it relates to Medicaid? So or the cabinet in general. We're always happy to invite our sister agencies to come to these meetings. And again, appreciate DCBS for being here to provide the update on HR1 and its impact to SNAP. So if there are particular areas that you want more information about, please let us know. We're happy to provide that in a future session. But otherwise, we've tried to keep up with the questions and appreciate that engagement in the chat. And we'll end the meeting and hope you have a great rest of the day. Thanks for being with us.